All of the resources that are here today are wonderful, and I would encourage each of you, if you haven't had an opportunity to speak to the representatives and pick up information at their tables, they will be available through the program, and you can stop by their tables afterwards as well. Before we start our program, I'd like to give Karen from the Caregiver Resource Center just a couple of minutes to say a few words about some of the things that are affecting their resource center as a result of the state budget. So, Karen?
Thank you. At the Caregiver Resource Center, we work with family who are caregivers for a person with just about any kind of illness. We are here to support you with support groups, classes, resources, and social workers to work with you individually. There are 11 caregiver resource centers in California. We have been in existence, the Orange organization has been in existence almost 25 years. The original Caregiver Resource Center started in the 80s. We are state funded, and as such, we are on the governor's chopping block to have our funding cut, and that would be all of the Caregiver Resource Centers throughout California would no longer be receiving funding. We are asking you, if you are a caregiver, to consider signing a letter to the governor asking him to please reconsider cutting the funding to the Caregiver Resource Centers. There is no other organization that works just with caregivers. It's important for caregivers to be supported because statistics show that caregiving can be extremely difficult. So we are hoping that you would be interested in supporting our organization. We have flyers back at the table back over there. If you could, on the front it talks about what's happening, and on the back it gives you an example of a letter you might possibly send to the governor. He hasn't made his decision yet. We're kind of waiting with bated breath to see which way it's going to go for us, but I would appreciate it if you consider it to send a letter in to the governor to let him know that you support the Caregiver Resource Center. Thank you.
Okay, and a couple of quick announcements. At each of your seats, you should have handouts for tonight's program that you can follow along with the presenters. Also, you'll find a one-sheet evaluation form. This is really important feedback for us. If you could kindly complete that evaluation and make sure to turn it in at the front desk before you leave. Your feedback about our program and the service that we are providing is very important for us, so we ask that you please complete that. Also, if you are not already receiving mail, informational mail from UCI Mind and are interested in getting on our mailing list for future educational programs, our newsletter, or other helpful information, please feel free to complete one of the Keep Informed sheets that are also part of your packets, and you can turn those in also at the front desk. For those of you who enjoy the program, or who know others who would have liked to have been here but were unable to, we will actually be posting this forum online at our website. So you'll be able to listen to the speakers and follow along with the presentation online as well. So please check our website in the future. It usually does take a few weeks, several weeks, but it will be available. So please check on our website for when that is available. Okay? Now, without further ado, I'd like to introduce our speakers for the evening. From UCI Mind, we have our senior neuropsychologist, Dr. Malcolm Dick, and also our Director of Education, Dr. Cordula Dignol. Thank you.
Great to see you all here. Might I ask how many of you are first timers? Raise your hand. Well, welcome to all of you. Thank you for coming, and I hope you enjoy what we have to offer tonight.
Can you hear us pretty well in the back? Okay.
It's just really important because we're talking about pharmaceuticals and various, medications that we let you know that we have no financial disclosures. In other words, we have no financial interests in any of the companies or products that we're going to be talking about. As Shirley said, this is the second of a 4-part series. you can see that the first session focused on the various types of dementias, and that particular session is available on our website now. So you can go ahead and find that under the Family Education Series on our website. Tonight we'll be talking primarily about the various medications that are available for Alzheimer's disease, and also some of the emerging therapies and strategies that we are looking at to address the disease. In September, we'll be focused on addressing the behavioral symptoms in Alzheimer's disease, and that session will particularly focus on non-pharmacological ways to address these behaviors. So we're going to be talking about management strategies, communications, and so forth. And then finally, in December, we're going to talk about how you can reduce your risk for Alzheimer's disease, lifestyle strategies, and so forth, which you hear about in the news a lot today. So we're going to review those for you. If you would like to keep coming and be notified, as Shirley said, of these events and also other things that we offer at UCI Mind, do make sure to fill out one of those slips. So just to bring you up to speed, this is the newest data released from the Alzheimer's Association. We have 5.4 million people with Alzheimer's today in the nation, and remarkably, we have 15.2 million caregivers. That means we have 3 caregivers for every person with this disease who are involved in providing the support that individual needs. Today, another American develops Alzheimer's every 68 seconds. By middle of the century, when we expect at least 13.5 million people will be affected, one person will be developing this disease every half minute. This is just a collage of all the various famous people that have been affected by Alzheimer's disease. Alzheimer's disease knows no boundaries. I know you all know that President Reagan had this disease, and for fun, well, 2 of the most prominent individuals right now who are still alive with the disease are, and up here, Pat Summitt, Coach Pat Summitt, and those are the 2 living individuals on here. Other people, Sergeant Shriver, moving over, help me out, test your memory. Jack Lord, Hawaii 5-0. Harry Como. This one over here on the corner. Yes, very good. Moving down. Dana Andrews. Peter Falk, right? We talked about Glenn Campbell. Over here.
They said it, Gene Barry.
Gene Barry, going down. I heard that one. Somebody mentioned this one. Charlton Heston.
Charles Bronson.
Bronson, excuse me. And this one? Yes. And here, David Niven, down. Yes, Charlton Heston there, sorry. And here? Famous painter. Yes.
Sugar Ray Robinson?
Mm-hmm.
Yes, Sugar Ray. Who's that? Who's this right here? Scotty. Anybody know what his real name is? Montgomery Scott. And up here, anybody recognize this singer from the 1960s? No, Bobby V, I heard it. Somebody got it. Good for you. Bobby V. And then over here? Arlene Francis, yes. Now, some of you have had practice because you've seen me show this slide before. I heard a voice from back there, but.
They're getting more and more people up there, and they'll be so small, we'll never be able to recognize them.
I know, I squeezed, I did, you're right. Also, I don't recall if Shirley said, but we are gonna have questions at the end, so we're gonna try to save some time so we can get through this information. As I mentioned, we expect to have 13.5 million by 2050 affected by Alzheimer's disease here in the United States. here in Orange County, as you can see, the number of people affected by this disease is going to double by 2030, just 18 years from now. That's a significant increase, especially when you add the 3 caregivers for every 1 person with the disease. So if you have 100,000 people here in Orange County with the disease, another 300,000 caregivers, that's 400,000 individuals that are directly affected. So today we're going to talk about how we're going to make progress in this disease through research and how you can help. Briefly give you an overview of the course of from normal aging to MCI and dementia, and then focus on the treatments, the available treatments, and some of the emerging treatments. So I wanted to just start by saying that I hope that you appreciate that everything that we teach you about today is a result of research, and many, many decades of research, and what has made that research possible. Most people think about money. We need money for research, but actually CBS recently did a spot on TV, and one of the other reasons we don't make progress in the field of Alzheimer's disease is because of the need for research volunteers. So it's not just the money, it's all the research volunteers that over the decades have been willing to participate in research that we've been able to make as much progress as we have. And so I just wanted to let you know that here at UCI Mind, we need research volunteers, and hope that you might be inspired to help. We follow several groups of individuals. We follow a group of healthy older adults, and we also follow a group of people with what's known as mild cognitive impairment. You'll hear more about that tonight, sort of a pre-Alzheimer's stage, and then people with early Alzheimer's or another dementia. And these people allow us to follow them until death every year, and they also allow us to use all the data that they contribute, whether it's in the form of cognitive testing, or they might contribute their blood, they contribute their brain at death, they contribute cerebral spinal fluid. They allow us to use all that to study the disease processes. So if you happen to be interested in getting involved in research here at UCI Mind, Peter and Swit are in the back, and you can fill out one of those forms we handed you today, and you have the information summarized on the slide about what's involved. So let's move on now to talk about the course of from normal aging through dementia. How does that progress? And we'll start first by clarifying what the term dementia means. It's very important to understand the difference between dementia and Alzheimer's disease. So dementia is what we consider a syndrome, and it's characterized by 3 different factors. The first one being a loss of intellectual ability. The second is that it affects your memory plus 1 or more other cognitive abilities. And the third is that the impairment is so severe that it interferes with your everyday life. At first with your work, maybe your ability to drive, your social life, and eventually it impacts even your ability to take care of yourself. It happens to be that Alzheimer's disease is the most common type of dementia, although there's many others. We're going to show you just a second. And mild cognitive impairment is that state in between normal aging and Alzheimer's disease. It's a transitional state that we're going to describe to you that increases your risk for developing Alzheimer's.
Well, just in the last year or two, clinicians and researchers now talk about the development of Alzheimer's disease differently than we talked about it, say, 10 years, 15, 20 years ago. Now they talk about these 3 stages. There's a preclinical stage where there actually are changes that are occurring in the brain, and we'll talk about some of those in a minute. And these changes can be taking place years and even decades before there's any clinical symptoms evident. As these changes start to occur and multiply, eventually the individual will start showing these cognitive changes, typically memory loss, but other difficulties as well. And at that stage, we diagnose an individual as having mild cognitive impairment. And as those changes continue, because it is a progressive disease, eventually the individual goes into a dementia. And we were going to discuss each of these 3 stages to help you understand.
So first of all, what can we expect in normal aging? And you're going to see several slides that look just like this, where this axis here represents the cognitive decline, so the vertical axis. The horizontal axis represents time in years. And so what we know is that as we age, it's normal for us all to experience some cognitive changes. So we see this slight change in normal aging. Well, what are the kinds of experiences we might have that are typical? Well, it takes us longer to learn new information. So a good example of that is when you are introduced to new people and you're learning their names, that it takes more effort to actually learn a name. It's very easy to forget that name and difficult to recall it. So it takes harder work. We're more susceptible to distraction, so maybe we can't read a book and have the radio on or music on at the same time anymore. It takes us longer to recall information. We might have difficulty also finding words. You know, the tip of tongue phenomena, where you have a word that you want, but it doesn't come back to you. Then it comes back to you maybe half an hour later or an hour later, not when you need it. And it's harder for us to multitask, to do many things at once. So these are all things that we're going to typically experience during the aging process.
This change, where the individual is aware of a problem, but maybe other people are not, is referred to this preclinical or asymptomatic stage. And it started to be investigated quite a bit now in the last few years. And some doctors refer this to as like a stage where the person knows that there's a problem. They know that their thinking isn't as good as it used to be. But if you do formal testing, they still score in the normal range. They seem perfectly fine. A little bit about the brain. Where are these changes taking place? Well, this is just a model of the brain. This is the front, obviously the nose and eyes. And this is the back of the head. Your ear would be right about here. And if you go in from the ear, there's this part of the brain called the temporal lobe, which is the part of the brain involved in learning and memory. And there's a particular structure called the hippocampus, which is this organ right here that is on both the left and the right side. And the hippocampus is the part of the brain that's often affected earliest in diseases like Alzheimer's disease.
So what's happening in Alzheimer's disease? As you can see, there's these billions of neurons or brain cells, and there's 3 things that they need to stay healthy. One is they have to be able to communicate, and that happens by transmission of basically an electrical charge from one neuron to another across the synapse, and then to carry out metabolism and to repair themselves. So metabolism being the process that allows them to grow and to reproduce. All 3 of these processes are actually disrupted in Alzheimer's disease. So here we see
This is a model of 2, actually these are 2 actual photographs of real brain tissue. They're from individuals who came through our clinic. They're both women in the mid-60s who died. One was a healthy adult and one had Alzheimer's disease, probably in the moderate stages. And you can notice a couple of differences on the surface of the brain. As we all age, our brain does show some shrinkage, just like as we age, we shrink in height. We're not as tall as we used to be. Our muscles sort of atrophy, they become weaker. Well, we see the same thing in the brain, where these hills and valleys become more separated due to a shrinkage in them. And this shrinkage or loss of brain cells is a result, we think, at least scientists do, of pathological changes called senile plaques and neurofibrillary tangles. So this is the view of the brain that you would have if you just scanned it with your eye. If you sliced the brain tissue, stained it with certain chemicals, and looked under a microscope, this is what you would see in an Alzheimer's brain versus a normal adult.
Yeah, and just to remind you, everybody, this would be right over your ear. So you're looking at the brain this way, a side view of the brain.
So this is a temporal lobe in this lady with Alzheimer's disease. This is the temporal lobe in our healthy older adult. You can see the dramatic change, about a 50% or more loss.
So now we want to just show you the plaques and tangles that develop in Alzheimer's disease, and we're going to start by describing these senile plaques. And they're actually the spherical formations you see circled there. And what happens is that an abnormal protein called beta amyloid, that we're going to talk about some more, actually clumps around the brain cell, the neuron, and we believe that may be the cause of death of the cell. And so we're going to be talking more about this accumulation of beta amyloid in the brain and how some of the new medications are trying to address that. There are also neurofibrillary tangles, and these tangles actually are made up of another abnormal protein called tau. And so neurofibrillary tangles are actually abnormal, twisted, collections of twisted threads. As you can see, inside there's a cell, there's a microtubule, which is like a passageway, a passageway inside the cell. And you can see how the tau is breaking that down.
So an analogy for the microtubules is that they're sort of like little tiny straws going through the neuron. They're all nicely arranged, just like, say, railroad ties. And these railroad ties have their supporting structures that sort of keep them nicely aligned. Well, when this tau becomes abnormal, it's as if you have railroad tracks where the supporting cross beams are suddenly removed. They're torn up. And as a result, the rails become all twisted and information no longer can go up and down these microtubules.
Right, so you could imagine how it all folds in on itself.
So the tangles are essentially killing the brain cell from the inside, and the tau is sort of, and the senile plaques are killing them from the outside of the cell. Well, as these plaques and tangles start to occur in the brain, eventually they reach a stage where they are now starting to impact your mental abilities. And at this stage, when the cognitive deficit becomes obvious to other people, we now call this mild cognitive impairment. So in the preclinical stage, only the individual was aware of it. In the MCI stage, other people are noticing the problems. And they can extend beyond memory. They can affect your language, word finding, visual spatial abilities like getting lost, your judgment. One of the interesting things about mild cognitive impairment is that some patients don't necessarily progress to dementia. There's evidence that maybe about 20% of MCI patients may actually recover and go back to normal. Other MCI patients stay the same. However, a large group of them will progress, and they can often progress to a dementia like Alzheimer's disease. We do know that if you have MCI, you are at a greater risk of progressing to Alzheimer's disease. This is the rate of conversion or progression from normal aging to Alzheimer's disease, And if you look at large studies, it's about 1 to 2% of these normal adults will progress to Alzheimer's disease with each passing year. With MCI, the rate of progression is much higher. It's around 12 to 15%. So what does that mean? That means that after, say, a 5-year period, that individual who has MCI after 5 years is probably about a 60% chance of no longer having MCI, now having Alzheimer's disease or dementia instead. So having MCI is a great risk for progression to dementia.
So that's what this slide shows you, is that MCI is very likely to progress into a dementia. One of the things that is important to recognize is this is a very insidious process. So it's difficult. There's no finite point at which MCI ends and Alzheimer's begins. It's often difficult to tell where one ends and the other starts. And we already talked about the various characteristics of dementia just a little bit earlier.
So just as a quick example, let's take, say, a salesman who sells, let's say is selling cars. And in his best years, when he was totally fine, he could remember the names of maybe the top 30 or 40 clients who frequently purchased cars from his dealership. And he knew the person's names, their names of the wife, the children, what kind of vehicle they liked, what kind of amenities they liked. Now he starts to have some problems. He's in this preclinical stage. And he's still able to function quite well, but when his secretary says, "Oh, Mr. Smith is here to see you," he has to sort of now consult a little diary or a notebook about what is Mr. Smith's preferences in vehicles and what is his wife and children's names. When did he last buy a car? So he can't remember that offhand like he used to. But nobody in the showroom, none of the other salespeople even notice that he's got any problems. They think he's still doing well. If this continues, he might then go into MCI, where now his memory problems are becoming very evident to other people. So he's forgetting appointments. He's forgetting meetings. He's starting to have difficulty maybe finding his way around when he's showing customers the cars. And then if this continues, he may also have, say, personality changes like irritability and agitation, or depression, anxiety. And if it continues on, it would then probably go into a dementia, where he would no longer be able to work and not able to function anymore, okay, by himself. So these changes that we've talked about, the plaques and the tangles, they initially start in this temporal lobe area, a little bit above where your ears are, particularly in the hippocampus, and over time they slowly progress, extending more and more into the temporal lobe and into the frontal lobes. And then in the late stages, they're pretty much extended throughout the whole brain, with the greatest preponderance still in the temporal lobes. This next slide just shows sort of the level of atrophy. So in a normal adult, this is a cross-section of the brain. So you're looking straight at the person, and we're sort of taking an imaginary knife and just slicing the brain this way. So just slice here, and we open this up, and that's what you would see. The ears would be about here. This looks like a cauliflower leaf. This is the temporal lobe, and this area right in the middle is the hippocampus. And the hippocampus comes from Latin for seahorse, and it's actually shaped a little bit like a seahorse. You can see this would be like the head, the neck, the body, and the tail swooping down. As the disease progresses into MCI and a mild dementia, you start to see atrophy, a shrinkage on the outer surface of the brain, and also in the hippocampus region. And then in the later stages of the dementia, the hippocampus is pretty much totally gone. The person is severely impaired in their memory abilities. And we've also seen a loss of cells on the cortex, the surface of the brain, leading to other areas of dysfunction besides memory, like language, visual spatial skills. This next slide essentially shows what you could see on an MRI scan of an individual going from normal to MCI to moderate and severe dementia. And this is that cauliflower-shaped temporal lobe, and this is the hippocampus in normal, in mild. By the time you get into sort of mild atrophy or an MCI, you've probably lost about 50% of your hippocampal cells. And then moderate and very severe, where you can see the hippocampus is essentially totally gone.
So how long does this whole process take? And first of all, as Malcolm said earlier, there's a long preclinical stage before any symptoms are ever seen, which means we have these plaques and tangles developing in our brains for many, many years before you ever see symptoms. So that could be a decade or more. So I always tell people I could have Alzheimer's disease today and not know it, because right now we don't have a way to test it, to test my blood or another biomarker to identify it. Once the person goes into the MCI stage, you can see that that stage can last up to 8 years. And then when they progress to a dementia like Alzheimer's disease, that's another 6 to 9 years. So the average course of this is approximately 8 to 9 years. Total time here could be as long as 17 years, as you can see, where the person's actually showing symptoms, with many, many years before that where they're developing changes in their brain, and it's basically a silent disease at that time.
Well, this separation between normal and MCI, and between MCI and dementia, is rather difficult because there's not a clear sort of demarcation point. You can't suddenly say one day the person has MCI, the next day they've got dementia. There's a lot of overlap between these groups. So one way doctors are trying to see if we can maybe identify individuals at the earlier stages through biomarkers, blood tests, and there are a number of tests, both of blood and cerebrospinal fluid, that are under study that may be able to identify individuals at risk of progressing to dementia. Say if they have MCI, are they going to go into Alzheimer's disease, or is that MCI patient going to go maybe back to normal? And these biomarkers, you can show the next slide. Mm-hmm. There's a lot of research being done now looking at cerebrospinal fluid, where you go in at the base of your spine, you take sort of a little needle, you put it in, and you draw out spinal fluid. And you look for the beta amyloid and the tau proteins. And if you see certain levels, like low beta amyloid and high tau, then that might be, at least scientists think, an indication of future developing Alzheimer's disease. And these changes occur very early, often many years before the clinical symptoms become evident. Other newer techniques are looking at what's called a PET amyloid imaging, which is where you have a PET scan which looks at metabolism in your brain, and they actually inject a substance that will latch on to these beta amyloid fibrils that are starting to be deposited in the brain. And you can see this is a PET of a normal brain. This is someone with Alzheimer's disease or pre-Alzheimer's, and you can see the difference where all of this red and the yellow and the brighter colors are depositions of amyloid. We already do PET scans that show reduced blood flow and glucose utilization in Alzheimer's disease, and we also have MRIs which can show the atrophy. But these biomarkers and PET imaging are sort of possibly the new techniques.
Right. I think it's really important to emphasize that, especially the CSF. The CSF is investigational at this point, so it's not something you could walk in your doctor's office and he would say, oh, let's do a spinal tap to see if you have the early signs of Alzheimer's disease. But I wanted to emphasize, why is this important? It's very important because these signs, the signs that we're looking for now in cerebral spinal fluid, they occur much earlier than other types of changes. So you can see, for example, the dark line here, the CSF A beta, so that's the abnormal form of the beta amyloid, the A beta 42. Those changes start occurring way out here in the pre-symptomatic stages, long before you ever have any evidence of MCI. So if we could identify a decade before you had MCI, that you have some of these abnormal changes in your CSF that indicate that you're at risk for Alzheimer's disease, then imagine we could start treatment that much earlier. Now, that's much earlier than we can see, for example, MRI changes. MRI changes, you can see the line starts to go up here versus the CSF, which is evident here. So it's much later on that the current ways that we look for the disease are actually evident. Cognitive performance, this dark green line, look at that. The changes happen way out here in MCI, much later than those hidden silent changes. So that's why there's so much emphasis now on trying to find biomarkers for this disease, so that we might be able to treat it earlier while it's under its initial stages of development. One of the messages that's so important is there's still a predominant thought out there that once a person gets diagnosed with MCI or Alzheimer's disease, that there's nothing that can be done. And that's something we really want to clarify or rectify, because actually Alzheimer's disease is very treatable. It's not curable yet, but it's very treatable. And so there's a lot that we can do from a medications perspective, but also from a more psychosocial perspective to help the person and to help the family. One of the issues that's really of great concern is that because there's this belief out here that nothing can be done, and it's a belief that's widely held still in the community, and it's widely held among physicians that people don't get diagnosed. And the longer we delay diagnosis, the longer we delay treatment. So you can just see some of the statistics here about how often physicians miss cognitive impairment in their patients. Up to 70, I think this is really amazing. It's undetected in 91% of people with mild symptoms and up to 76% of people with moderate to severe symptoms. So again, we need to change our approach and our attitude towards Alzheimer's disease, stop dismissing it as just growing old, and recognize that cognitive changes could be indicative of a problem that is treatable.
The treatment for, the focus of treatment is obviously going to vary depending on the stage the individual is in. So if we're dealing with somebody who is in the very early stages, mild stages, where they may have still a high degree of independence, the focus of treatment would be to try to slow the progression or to boost up or improve your cognitive functioning. If the person is in the more advanced stages, you don't necessarily want to slow the progression, but you want to maybe try to handle behavioral problems or caregiver stress, things like that, and maybe try to address the safety.
So let's talk about the medications that are currently available today, what they do and what they don't do. And we have been looking for a drug to address Alzheimer's disease effectively for decades. And we'll tell you a little bit about the history of pharmaceuticals in Alzheimer's disease. But this, in some sense, is not a new battle, because the first complaints, actually, or records of memory loss and aging date back to ancient times. Descriptions of age-related forgetfulness actually can be found as early as the 9th century BC. So this has been a problem that's plagued humankind since its existence. But this is just a cute little slide, and again, some of you have probably seen me show this before. but this is brain salt from 1892. It's for brain troubles, headaches, seasickness, and you can see in there, over brain work, excessive study. So, there's always been this pursuit of how we can maximize our cognitive abilities. So Alzheimer's disease was discovered in 1906 by Dr. Alzheimer in a woman named Augusta D. And I think what we always like to point out in this slide was look how many decades it took before we first obtained our first drug, 1993. It's actually about 9 decades that passed by. Why was that? Well, originally, Augusta D was in her early 50s, and when Dr. Alzheimer identified the disease, the abnormal plaques and tangles in the brain, the disease was named after him. It was thought that this was a rare disease. It happened in younger people. It was very unusual. And so for many, many decades, it was believed that it wasn't recognized that the predominant cause of cognitive impairment in the elderly was Alzheimer's, and many people were misdiagnosed as having arteriosclerosis. In the 1970s, we developed the first hypothesis about how Alzheimer's disease occurs. We're going to talk about that because many of our current medications are based on this cholinergic hypothesis. We no longer use the first drug, Tacrem, because of the toxic side effects that it had, and it required liver tests every 6 weeks. We now rely on the subsequent drugs, donepezil, rivastigmine, and galantamine, which are all based on this cholinergic hypothesis. And then more subsequently in 2003, that's when the last new drug was released, memantine, and we'll talk to you about that. So what can we expect out of a treatment? We would like this line here represents placebo. So if a person receives no drugs, the hypothetical line of decline across the progression of Alzheimer's disease. What we'd like to do is we'd like to be able to slow the progression of the disease. We'd actually like to modify the disease course. If we did that, the slope would be up here, and when we take the person off the drug, we'd actually see that they've actually continued to perform much better than the hypothetical model here. But today, what we have primarily is symptomatic treatments. That means that they boost you up for the time that you're taking the drug, but when you stop the drug, you go back to where you would normally have been without the drug. So you'll see some more examples of that.
Well, the theory that sort of led to the development of the current drugs is this cholinergic hypothesis. And we do know that in Alzheimer's disease, there's many neurotransmitters. Neurotransmitters are the chemical messengers that allow one brain cell to send messages to the others. But one of the key neurotransmitters that is deficient or lost in Alzheimer's disease is one called acetylcholine. And acetylcholine is very important for the functioning of the temporal, the frontal, and the parietal lobes, where a lot of our thinking abilities take place. And we do know, for example, that in Alzheimer's disease, patients can have anywhere from a 40 to 90% loss of acetylcholine compared to a healthy adult. I'm going to show you in the next slide how this acetylcholine works. So remember we talked about how in that earlier slide there's probably 100 billion brain cells that you have, 100 billion neurons. Well, those neurons do not actually touch one another. There's this little gap between them called the synapse. And the way one cell sends a message to the other is it releases this neurotransmitter that floats across the synapse or the gap, and then it hits receptors on this postsynaptic neuron and it picks up the message. This is the acetylcholine being released, these little red ovals. there's a naturally occurring substance in our body that breaks down acetylcholine. It's called acetylcholine esterase. Think of the word esterase like an eraser. What it does is it erases or removes this acetylcholine. There's also another substance called butyrylcholinesterase. So you can use that next time you're playing Scrabble. So butyrylcholinesterase, and butyrylcholinesterase in a normal adult is hardly present in the brain. But as a person develops Alzheimer's, this butyrylcholinesterase, which also removes acetylcholine, becomes more and more evident. And so you can have 150 or more % increase in butyrylcholinesterase in an Alzheimer's brain. So both the acetylcholinesterase and the butyrylcholinesterase are getting rid of this acetylcholine, the transmitter. Efforts have been done for many years to try, well, can we get more acetylcholine into the brain? Why don't we just find a way we can give them substances, injections, or foods, et cetera, that would build up the acetylcholine? Well, unfortunately, it doesn't pass into the brain. It doesn't go into past the blood-brain barrier. So the way these drugs all work is that they inhibit or they stop the working of the erasers. So by inhibiting the acetylcholinesterase or the butyrylcholinesterase or both, you end up increasing the amounts of acetylcholine. And that leads to somewhat of an improvement in performance. This is just a slide showing the levels of acetylcholine in someone with Alzheimer's disease compared to a normal adult. And you can see the levels of acetylcholine are markedly reduced in the hippocampus, the temporal lobe, the parietal and frontal lobes that are all involved very heavily in our cognitive abilities.
So you actually have a much larger version of this slide for your reference.
It should be on the back.
Yeah, it basically summarizes the differences between the three drugs, how you take them. So for example, Aricept, which you can take once daily without food, versus Exelon, the Exelon patch, and then Razidine, and Razidine extended release. So it also provides you with the dosages, the starting dosage, the maximum dose, the recommended dose that you want to get to. We'll talk more about dosing. How long it takes to bring the person up. Titration is how long does it take from the starting dose to get them up to the highest dose. That's what titration is. The half-life, the time to eliminate the drug from your system, and then the mechanism of action. So what does inhibit? So in this case, you can see that donepezil or Aricept inhibits acetylcholinesterase, while Exelon works on inhibiting both acetylcholinesterase and butyrylcholinesterase. I think the slide is actually self-explanatory in terms of outlining the differences.
Yeah, all of those drugs except the Exelon patch are generic now. So there's generic versions of them. And we put some prices, I think these are from last year. But they are pretty comparable in costs. There's not one obvious reason to choose one drug over another based on cost differences.
What's the nicotinic?
Razidine or galantamine, what it also does is the pharmaceutical company would argue that what it does is it also stimulates the nicotinic receptors, and these are receptors on the presynaptic neuron, the one that is releasing the acetylcholine, and by stimulating them, what it does is it causes it to release more acetylcholine into the synapse. So both the makers of Exelon and galantamine, they would argue that their drugs have a dual mechanism. Exelon inhibits both acetylcholine and butyrylcholinesterase. Galantamine inhibits both acetylcholinesterase and also stimulates these nicotinic receptors to release more acetylcholine. Now, whether that has any clinical benefit, it's still unsure. But theoretically, they would argue that it may have this dual mechanism.
So when we think about these drugs, we have to think about the 3 areas of functioning that are affected by Alzheimer's disease. So the 3 major areas that Alzheimer's disease affects are your cognition, memory, language, reasoning, judgment, your behavior. So you develop behavioral and psychiatric symptoms, agitation, anxiety, and depression and so forth. And then your activities of daily living. It impairs your ability to do your everyday self-care tasks eventually. So when we look at the medications and the impact the medications have, we need to think about the impact they have on all 3 of these areas. And these drugs, as you'll hear, they were created to improve cognitive function, but they can also be beneficial for these other areas as well.
So I just wanted to show you a couple of slides looking at some of the data from those 3 drugs. And the slides sort of focus on the cognitive changes, and they use, all of the drug trials use a standard set of tools so they can compare one drug's benefit to the other using the same metric. And the drug tool that is commonly used to measure cognition is this one called ADAS, or Alzheimer's Disease Assessment Scale. And the way these studies they work is that individuals, say, who are given a placebo or the drug, they would be matched on their score on this cognitive test that measures memory, language, visual spatial skills. And then we know from many years of research prior to these drugs becoming available that individuals with Alzheimer's show a relatively standard rate of decline across time. They drop by about 7 to 9 points per year on this test. So if you give a drug to these individuals and they show much less than a 7 to 9 point decline in a year, then maybe that drug is actually beneficial. And that's what the focus of all of these clinical trials is. Does the drug reduce the amount of decline that you would expect after 6 months or a year? This is a study just looking at Aricept or donepezil. And all of these studies follow the same sort of format. They have a high dose, 10 milligrams, and the starting or low dose, 5 milligrams, and they compare it to placebo. This is where everybody started at the beginning. Everybody was equal. And then over essentially about a 6-month period, they looked at how much decline occurred in the high and the low dose group. And what they found is, you can see the difference here between, say, 2.5 point loss in the placebo group and about a 1 point gain in the treatment groups. So you've got about a 3 or so point difference after 6 months. So this represents an actual positive finding, an improvement with scores or no change. When you take the people off the drug, so everybody in his group was discontinued from the medicine, what you find is that everybody goes down to about where they would normally be without the drug. So this is showing that it produces a symptomatic benefit. It doesn't alter the course of the disease, because once the drug is removed, you sort of lose that ground or that benefit that you've gained. So it's a symptomatic improvement, it's not a disease altering. The next slide shows performance with another drug, Exelon. And this is an interesting slide because this is showing this high dose and the low dose compared to placebo. And what they did, you can see the high dose and the low dose were better than the placebo after about 6 months. Everybody at this point was given the drug. So the placebo group suddenly was now not just on a sugar pill, but they got the drug. And what you can see is that the placebo group went ahead and showed some improvement. This is what you would project if you didn't give them the drug. This is a sort of a projection of the placebo group, dropping about 7 to 9 points after a year. So the take-home message from this study was that not only did the drug have a beneficial effect, but if you started the drug late, so you waited 6 months, started it late, You did show some improvement, but you never reached the same level as the people who started the drug early. So the take-home message was to start the drugs early, not late. These drugs also seem to have a beneficial effect over the long term. There's some controversy about whether the drugs lose their benefit after 6 months, a few years. Well, these studies, which were done with galantamine or Razidine, this is a treatment group, and even after 36 months or 3 years, they were about 50% better than what we'd expect in patients who were not being treated. So the drugs do seem to have some lasting benefits that can last up to 3 years with these cholinesterase inhibitors. Overall, if you look at combine all of these cholinesterase inhibitors together, they all seem to produce some benefits. There's not clearly one that is superior to the other. They all seem to produce about the same amount of improvement compared to placebo. Well, how do you select which drug to give? Well, that's often a decision that the doctor would make with the patient, discussing the pros and the cons. And the doctors would consider a number of features. For example, they have to look at what other medical conditions are present. So for example, if the patient has difficulties with their heart, or they have liver impairment, liver cirrhosis, then you might want to avoid certain drugs that are metabolized by the liver, such as Aricept and Razidine. And you might want to choose, say, Exelon. One of the side effects of these drugs, all of them, is that they increase the amount of stomach acid your body is producing. So if you have a propensity to a stomach or intestinal ulcer, you might want to be very cautious about using these drugs because it could increase the risk of the bleeding ulcer reoccurring or developing. So there's medical choices that you have to consider when selecting the drugs, and some might be better than others. There's also potential drug interactions. So for example, these drugs can interact with some of the non-steroidal anti-inflammatories, like Aleve, Naprosyn, and that can also worsen the risk of getting a stomach ulcer. The drugs can also interact, at least some of them, with antidepressants. So for example, Paxil, which is an SSRI antidepressant, can interact with Aricept, causing increased agitation in your patient. So there's multiple drugs that many older adults are taking, and the doctor would have to look at each of the drugs and figure out, is there any potential for an interaction with one of these cholinesterase inhibitors? Okay.
So one of the things that people, of course, are concerned about are what are the side effects of these medications. And you can see that the most common side effects are gastrointestinal. Malcolm already mentioned that they increase stomach acid. So the most common ones here are diarrhea going across, and also nausea and vomiting. Now the percentage of people who experience these side effects in the clinical trials varies greatly. You can see that Exelon tends to have the highest, the Exelon capsule form tends to have the highest rate of gastrointestinal side effects. You can also see that the patch form has one of the lowest rates of these side effects. So sometimes when a patient can't tolerate the other drugs or can't tolerate Exelon, they'll be responding better to the patch. And we'll be talking about strategies to decrease the occurrence of these side effects, because how you actually titrate the patient on to the drug can actually affect or reduce these side effects.
One of the reasons for that is if you go back and look at that table, the half-life of the Exelon pill is about an hour and a half. So you get a big influx of the chemical into your system. The patch is a 24-hour patch. So you wear it, and over a 24-hour period, it is slowly giving you the medicine through the skin. So you have less side effects simply because your system isn't suddenly bombarded with a high dose of this medicine. There's ways you can minimize these side effects. One of them is the use of food, for example, will help, not with the patch, because you don't eat the patch, you put it on your skin, but some of the drugs you can have a meal and it'll help with reducing the side effects. Usually if the side effects occur, they occur during the first few days or weeks of being on the drug. So typically if the patient and the family, if the side effects aren't very severe and aren't making life uncomfortable, if they just persevere, that queasiness or that nausea may go away within a few days to a week. If they become very severe and are disturbing to the patient, then you can typically maybe discontinue the medicine, have a washout period, 3 to 7 days typically, and then once the side effects have gone away, you might restart the person at a lower dose, or if need be, you could consider switching to another drug. So I think it's important to remember that the side effects will often go away after a short period of time. Well, the patch, a lot of people use the patch. The patch, as I said, has very few side effects, but the patch does have some possible side effects. One of them is skin irritation. And so with the patch, they typically recommend moving it around your body using a different location over a 2-week period and cleaning the area of the skin where the patch was previously on, just to make sure you don't get a skin irritation. You can also extend out the titration period, and this is a study where they looked extending the titration phase, or until you go from the 5 to the 10 milligram dose, from a week to 4 weeks. And this is a percentage of people who after a week went from the low to high dose versus went from the low to the high dose after being on the low dose for a month. You can see you almost half the side effects profile. So going slow, being on the low dose for longer periods of time is sometimes very helpful for reducing side effects.
Malcolm, since we only have 20 minutes left.
Either we talk really fast or...
I have to say, I kept trying to hint and he wasn't like picking it up. We have 20 minutes left and we have a lot still in the handout, as you can probably see, so I'm not going to say too much about this slide because
Okay.
it really summarizes everything Malcolm has just said. I know, I need to bring a little timer, don't I? I'm going to put it right in front of him. Malcolm already, well, switching. We haven't talked about switching too much, but we shouldn't give up, because if you're not responding to one drug, as you can see, 50% of patients actually respond to another drug. It's important to try the various options. And it's not necessary that the same side effects will occur. So we're going to talk just briefly about Namenda. Namenda actually has a different mechanism of action, and as you can see there, it works on a different neurotransmitter or chemical in the brain, glutamate, and glutamate is an excitatory neurotransmitter, and we believe that there actually could go either way, be too little glutamate or too much glutamate contributing to the death of the cell. So Namenda actually works on this particular neurotransmitter, but regulates the level of the neurotransmitter.
So essentially, if you've got too much glutamate, it's like your brain cells are in hyperdrive. They're sort of firing and going to burn themselves out. So Namenda would then lower the levels of glutamate, and by doing that, it has a protective effect. It helps to preserve your brain function.
How does glutamate get in the brain?
Well, that's a complex process that I don't even understand. So,
Because I take L-glutamine when my neurologist says it doesn't hurt me.
well, it's very complex. Now, the Namenda has been approved for moderate to severe Alzheimer's disease, and that's in the next slide here. It does regulate the glutamate, but it's been recommended for moderate to severe Alzheimer's disease, so that's what the FDA got approval for. Probably about half of neurologists will use Namenda with patients who are in the earlier stages. When you look at the research, it doesn't seem to have any, it's well tolerated. It doesn't seem to, however, produce much of a way of a benefit in terms of cognition or functioning. The goal, I think, that they're thinking, the neurologists who are prescribing it for early stage individuals, is that it might be helping to preserve or protect the brain.
Well, L-glutamine, when it crosses the brain barrier, becomes glutamic acid, and doesn't stay as glutamate.
Right, one of the things we agreed was we were going to ask questions at the end, because I just called time and we're not going to get through if we get too focused on.
I'll get more and more into trouble.
You're digging a hole here. I'm never going to be able to dig them out.
So these next few slides are just essentially showing the same thing, that the Namenda-treated groups did better than the placebo group on measures of cognition, on activities of daily living. Go ahead.
And then here, one of the things, as I mentioned earlier, it is important to look for benefits other than necessarily in cognition, because it's really important to caregivers whether their loved ones can do some of these simple tasks still. And you can see that this is the amount of decline, and that, again, people on Namenda declined less than those on placebo. So they were more able to use a telephone or to clear a table than people on placebo who declined, and they actually improved at making a conversation. And that can be very important to the caregiver.
Well, what happens if you have people taking both, say a cholinesterase inhibitor and Namenda? And this was the results of some studies where this individual Tariot took a group of over 400 Alzheimer's patients who had been on Aricept for 2 years. And then half of them got Namenda and half got a placebo. And he looked to see what would be the benefit. So the placebo group here are already on Aricept, and you can see that they did show some decline. If you go back a few slides, we don't need to go backwards, but if you just look back a few slides and look at the placebo group who aren't on Aricept, on this measure of cognition, they declined by 10 points after 6 months. The group on Aricept declines by about 3 points. So Aricept by itself was helpful, but when you added Namenda in, you can see that was even more beneficial. So the combination of both the Namenda working on glutamate and the Aricept working on acetylcholine was better than just Aricept alone. And you see the same thing when you look at activities of daily living. This is an improvement compared to what would be with placebo. It was about double that in the previous slide. When you add in Namenda, you show a benefit above and beyond what you get with Aricept alone.
So again, looking at side effects here, Namenda actually does not have those gastrointestinal side effects that are of concern with the acetylcholinesterase inhibitors, and overall the rate of side effects with Namenda is very low. And sometimes even with combining Namenda with Aricept, Namenda can help to reduce, or with an acetylcholinesterase inhibitor, Namenda can actually help to reduce the gastrointestinal side effects of the acetylcholinesterase inhibitor.
So I think there's positive benefits you can get from taking both drugs. Again, Namenda is primarily recommended for patients in the moderate to severe stages, but some neurologists will use it in the earlier stages. Interestingly, some studies suggest taking both drugs may reduce the incidence of the gastrointestinal side effects that you get with just the cholinesterase inhibitors alone. Go ahead.
Just in summary here, we already talked about the importance of recognizing that Alzheimer's disease is treatable. These medications can have a positive effect. The earlier the treatment is started, the better it is, the more likely to have a positive effect. And the more improvement, the higher dose you're able to take of these medications, the higher dose you're able to tolerate. As we said, the benefits can be long-term. One study had showed up to 3 years. And we talked about strategies to minimize the side effects, such as titrating people over a longer period of time onto the drug.
I think one of the big things that about half the people who start the cholinesterase inhibitors discontinue within about 3 to 4 months. Why is this? I think the reason is possibly side effects, but I think the other reason is that people have unrealistic expectation about what these drugs do. A lot of times people will go to their doctor and they'll say they've heard about Aricept or these other drugs, and they'll think, we'll give mom or dad or my spouse that drug, and they'll go back to being normal. Well, these drugs do not do that. They are a symptomatic benefit. They boost up your thinking or your functional abilities. But so long as you're taking it, if you stop taking it, then you go down. So I think a lot of people have a misconception that these drugs will improve functioning, take you back to how you were when you're a healthy adult. That's not the case. Actually, if they can keep you steady or stable or a slower than expected rate of decline, then that's actually positive. So the last words here, no change in functioning, is actually probably meaning the drugs are having some benefit.
So I think we can skip this one. That summarizes again. And we can go on to talk about the acetylcholinesterase inhibitors in MCI. And this slide just reminds you of the process. We've talked about this again. I think we can, in the interest of time, skip over this. You're familiar with the model?
Well, one study that probably the most well-done study with MCI, they looked to see whether or not giving them Aricept would stop that conversion. As we talked about earlier, the person has about a 12 to 15% rate of conversion from MCI to dementia. Well, the goal was if we gave MCI patients, would it prevent them from converting? Would they stay normal or MCI? And so they compared high doses of vitamin E to Aricept to a placebo, and they followed people for 3 years. And the next slide shows the probability of not converting to Alzheimer's, and you can see the placebo group over the 3 years, they eventually, about half of them were demented by the end of the 3 years. This is with the vitamin E. High doses of vitamin E really had no benefit in terms of reducing the risk of conversion. And what they did find with Aricept was that there was a reduction in the risk of conversion. So the Aricept group had less risk of conversion after 1 and 2 years, but by the end of the study, they were essentially about where everybody else was. So what that shows is that the Aricept may delay a conversion. So in other words, it doesn't stop you from converting into dementia, but what it might do, it might push it back a year or 2. And so that's often the reason that doctors are using these drugs with MCI patients, is that it might give you more time just being in the MCI stage and not being in the demented stage.
So what about some alternative and investigational therapies? We've already talked about the difference here. You know, we'd like to have a cure, but absent a cure, we'd really like to slow the progression of the disease. Right now, we're getting a symptomatic benefit. So, and this just simply shows you of the, from a study that was done in 2010 by the Alzheimer's Association, the percentage of people today, or in 2010, that were in the mild, moderate, and severe stages of Alzheimer's disease, and what that'll look like in 2050 when we have 13.5 million. Why this is important, and we're reviewing this, is what if we actually had some treatments that could either slow the progression or delay the onset of the disease. And they looked at how the numbers would change of the people affected and the severity of the disease. And if we were able to delay the onset by 5 years, push back when the disease started by 5 years, we'd actually be decreasing the number affected in 2050 from 13.5 million to 7.7 million. That is hugely significant from a human cost perspective, but also from a societal cost perspective, since today it costs us $200 billion a year to care for people with Alzheimer's. By 2050, that'll be $1.1 trillion. Now, what if we were able to slow the progression? Well, would look a little bit different. What's interesting is we'd actually have more people with Alzheimer's disease because we're slowing the progression, okay? But what we'd be doing is maintaining their quality of life, because in this particular pie chart, you can see that 60% of them would be in the mild stages versus today where versus the same treatments as today, only 23% would be in the mild stages. So slowing the progression would help us improve quality of life. That's why making advances in Alzheimer's is so important.
I think you should just jump to the amyloid, that one.
Okay. So what happens with beta amyloid? How does it actually form in the brain? So what's happening here is that the amyloid precursor protein, which is a precursor of the amyloid plaque, actually you can see here how it's sticking through the cell membrane. There's actually enzymes that snip this APP molecule, and they snip it into proteins, and that includes beta amyloid. So here you can see that snipping taking place. So when the snipping is taking place, if things are normal, about 95% of these fragments are A beta 38 to 40. Those are different forms of A beta. They're all non-toxic. They're all non-toxic to you. Only 5% is A beta 42. A beta 42 is the toxic form. And it's these A beta 42 fragments that cluster together and they form the plaques that we showed you earlier. We don't know why, but people with Alzheimer's disease develop more A beta 42 that then clumps into the plaques and disrupts the functions of the neurons, as we explained before, damaging the hippocampus and other areas of the brain. So basically, how are we going to intervene then? So if part of the problem is that these amyloid precursor proteins are being clipped in the wrong place, what can we do about that? Is there any way that we can stop them from being clipped in the wrong place? And we'll talk about these various interventions. Is there a way that we could actually prevent buildup or the clumping of the A beta 42 into the plaques? Are there ways to slow progression and maximize functioning or prevent neuron death? So you see this process from where goes from the fragments to clumping to neuron death. So there's different places in the process that we can intervene and that different investigational therapies are targeting.
So it makes sense, the idea that if we can prevent the scissors from cutting that amyloid in the wrong place, you might be able to reduce the number of these abnormal forms of the amyloid fragment that go on to clump together to form these pathological toxic elements. And so the next slide shows probably one of the main focuses for the last few years was this drug by Eli Lilly called semagacistat. And what they showed is that in animals, mice that were sort of genetically programmed to develop Alzheimer's, it did reduce beta amyloid. It didn't reduce it in the spinal fluid, but it did sort of in the blood show reductions. And they went sort of immediately from these animal studies, and some testing of the safety in humans, right into a phase 3 clinical trial where they had over 2,000 mild to moderate Alzheimer's patients who were then given this drug or a placebo. The placebo in this case isn't nothing, but rather it was the standard treatment. So these patients could be on Aricept and Namenda, et cetera. Unfortunately, what they found is that this drug that attempted to change where that scissors cut actually produced worse cognitive performance and worse functional abilities in the Alzheimer's patients being treated than those taking the standard treatment. And not only that, but the ones who were getting the drug were also at a higher risk for skin cancer. So they discontinued that trial. A next drug called Fluoxetine, this is also trying to affect where those scissors do the snipping. And this was well tolerated in both mice and in humans. And some preliminary studies with a small number, about 210 mild to moderate Alzheimer's patients, showed a reduction in the amount of amyloid, and also they did better on cognitive tests and tests of everyday living skills. And so they went ahead and tried it in phase 3 in a much larger group of mild to moderate Alzheimer's patients over a 2-year period. Unfortunately, the results of that study showed that the groups given Fluoxetine were no better at the end of the 2-year period than those given Aricept or one of the other cholinesterase inhibitors. So these gamma secretase inhibitors didn't seem really to work. There's still some drugs trying to maybe try to focus a little more and figure out maybe they need to be much more specific in where they cut, like Bristol Myers Squibb has a drug under trial still. But these have been very difficult to come up with a treatment. Another option is maybe if we can't sort of reduce the production, could we somehow prevent those fragments of amyloid from clumping together and becoming these plaques? Or better still, could we somehow remove those plaques from the brain? Could we sort of have something that'll go around scooping up and destroying those plaques? And this is sort of the next approach. And there's been a couple of drugs that you may have heard about. One is Alzmed. That did show some benefit in mice and also in moderate to mild to moderate patients. They actually showed a 70% reduction in amyloid in the CSF, cerebral spinal fluid. So they did a big multi-center, multi-year trial of over 1,000 patients. And unfortunately, the end result is that, again, there was no benefit over current treatment. So about the same time, there was a study looking at whether there could be a vaccine that would be developed. And this study by Dale Shank, what it did is it took mice that were at high risk. They're transgenic mice. They're going to be sort of genetically bred to develop Alzheimer's. So if you look at the mouse in its natural life, over time, over a number of months, about a year, it will develop all the symptoms of Alzheimer's disease. What they did is they took young mice, immunized them. What they essentially did is gave them beta amyloid at a very young age, injected it into them. The mouse then had their own immune system develop antibodies to that beta amyloid. And after a year, these mice were sort of living high off the hog. No evidence of Alzheimer's disease. And when they looked at the brains, what they found, this is the untreated or unvaccinated mouse, and this is the mice that had the vaccine. The ones that were vaccinated evidently developed these antibodies that essentially destroyed or removed 70% of the plaques. So this was very encouraging, and so they said, well, why don't we do this in humans? And so then they took these essentially humans, gave them a variant of this AB42. These were already patients who had mild to moderate Alzheimer's disease. And the goal was, if we give them this injection, would their immune system develop antibodies that would then attack the plaques, leading to a slower progression. And they were going to give 5 injections, but the next slide shows the results. And essentially, the study had to be stopped after 3 injections because about 6% of the patients with Alzheimer's disease developed an infection in the spinal cord and brain, sort of encephalitis, meningitis type. And the belief was that probably what happened is that their immune system became essentially overactive, and then it started to attack the brain itself. And so now the focus is on maybe don't have the patient's immune system develop the antibodies. Can we give them the antibodies, say, through an infusion? So this is called passive vaccination, where you don't have to produce the antibodies. We will extract the antibodies for beta 42 from healthy adults. We'll get all of these people in the room, get your blood and plasma, extract the antibodies, then give those in a very concentrated form to the patients with Alzheimer's disease. And that is what some ongoing trials are looking at. And this has the advantage of that it sort of sidesteps your own immune system, so you have a much less chance of developing this infection, this encephalitis, meningitis. You're much easier to control the amount of antibodies you give the person because you could give a large amount or a small amount. There are 3 drugs there are 3 studies that are using this passive immunization. I'm not even going to try to do the pronunciation. Don't ask me where they come up with the names for these, but these are ongoing studies, and the positive news is that probably the results of these studies are expected within the next year to 2 years. So hopefully in a year or 2, we'll be able to know whether or not these drugs are helpful or not in slowing the progression of the disease. And this is just a summary slide showing some of the sort of positives and the negatives. All of these ones, you may have heard of ones like Dimebond. We've talked about Fluorazen and Alzmed, the Semagacestat. All of those, unfortunately, were not successful. But we are still waiting for these ones, which are all using the passive immunization. And another one, Rember, which is actually trying to not look at amyloid, but rather look at the tau, the abnormal tau that causes those neurofibrillary tangles. The number of neurofibrillary tangles in the Alzheimer's patient's brain tends to be correlated better with their level of dementia and their cognitive impairment than the amount of amyloid. And so maybe by dealing with or addressing the tau and the neurofibrillary tangles, that might be another approach, a novel approach that has not been tried yet. So why did those other studies not work? Well, one idea that people have talked about is that maybe you're starting the drug trials too late. You're starting these drugs with patients typically who have mild to moderate Alzheimer's disease. Maybe instead of trying it with patients who are already in the middle stages of this disease, who've probably had it for over a decade, maybe you need to move forward in terms of earlier and earlier in the disease process. So maybe future drug trials will try to identify people who have MCI, who look at high risk of developing Alzheimer's disease, give the drugs to those groups before they have extensive brain damage and seeing if there would be a benefit. It's sort of like trying to treat somebody who's got coronary artery disease after they've already had multiple strokes and blockages in their vessels. Maybe you want to try to address them earlier in the disease where you can actually make a difference.
So I think Malcolm's already made that point that this slide illustrates. We want to try to make the interventions happen earlier in the pre-symptomatic phase. Oh, I'm sorry. Malcolm, that's fine. It's just repeating the point he just made. We want to treat earlier. And these are websites for clinical trials, and we're over time, so we'll take some questions. I'm sorry that Malcolm had to race through the last part of that. Sorry. Oh, there we go. Sorry that Malcolm had to race through the last part of that. So go ahead back there. Yes.
cancer drug that they found in mice destroyed the animal?
Yes, as I understand it,
Repeat the question, please.
there was this cancer drug that's used to treat cancer that showed some beneficial effects in terms of lowering amyloid in the brains of transgenic mice. And so I understand there is a clinical trial underway to see whether or not that can be useful. There are actually probably about 60 or more drugs in clinical trials. That small list we gave you are some of the ones that are upcoming that we should know the results of. But there are many different approaches being tried, and I think that's the positive news, is that there's so many different drugs, many different approaches being tried to see if we can reduce the number of Alzheimer's patients.
Yes, back there, in the black, right there.
You mentioned 3 years as a cutoff. Is that the research cutoff, or is there still more effectiveness after 3 years using these drugs?
Well, those are with the cholinesterase inhibitors. They showed a benefit even after 3 years, about 50% better than people not taking the drugs. We don't really know. We don't know. There's not been the studies that have looked at people who've been on these drugs 5, 10 years.
If you were to switch, like say after 5 years, to another one of those drugs, would that give a booster, a new?
I don't really know. I don't know of any research that has shown that. And there's some logic to it. So for example, if you've been on Aricept for a long period of time, we know Aricept from that table is primarily working on the acetylcholine esterase. Well, we know that butyrcholinesterase becomes more and more prevalent in the brain as the disease progresses, so maybe switching at some point might be beneficial, because now you would have Exelon attacking both acetylcholinesterase and butyrcholinesterase. But I don't know of any studies that have sort of looked over a long period, does switching lead to improvement or slowing the rate of decline.
So right here? Yes, right here.
How soon did you get started on the clinical trials? What age group? I was like identical twin sister, and we're 43 right now. And my mother is really average with it, and my mother before that. So.
Well, the question is, well, how early can you get started into clinical trials? Most clinical trials for Alzheimer's disease are using patients that have already been formally diagnosed with having mild to moderate Alzheimer's disease. I think in the future, you'll see more and more studies trying to identify patients in the MCI stage where there's definite changes. Plus, if you do these biomarkers, where you're looking at amyloid and tau levels, or doing a scan of the brain looking at amyloid deposits, you'll be able to say in this MCI patient, well, we think you are likely to go on to develop Alzheimer's, versus an MCI patient who's maybe got problems due to other causes that would be an improver.
So it has to be the MCI stage to have the biomarkers looked at?
Generally, we wouldn't probably be looking at your biomarkers. We are doing it on a research basis with normal adults, but we're not giving them the results. I think in the future there'll be more studies with MCI where there's biomarker evidence that they are likely to develop into Alzheimer's.
Okay, we'll just take 1 or 2 more questions. I know people are probably ready to leave. Yes.
To ask you, do you know of any studies where they're looking at food and your diet in relation to these diseases? Because there are a few holistic type doctors who really very strongly believe like you shouldn't have certain foods.
Like we serve tonight.
Well, I think we're going to be talking a lot more about diet and on the 4th session when we talk about reducing risk.
So we're going to be talking about diet, exercise, lifestyle, things like that.
So this is going to be the last question back there in the gray.
Yes, could you comment on Gamma that is currently in phase 3 trials? It seems to be an effective, seems to have a lot of promise. I was wondering if you could tell us how it acts and what you think of it.
Well, I would probably have to look up that medication and
If you
see the
leave-
mechanism.
Sorry, if you leave, would you please mind filling out your evaluation before you go? Thank you.
I'd be happy to look into that, but I think since there are a number of drugs in phase 3, and a number of them, as I showed you on those slides, had very positive phase 2 results, I think you really have to wait and see whether or not they actually produce the benefits that are sort of expected. Because many of the drugs, they have failed in phase 3 while they were very positive, like Dimebon and Florazan in phase 2.
Okay.
Maybe we'll be still here for a while, so people who have other questions, because we don't want to hold you back. I know we've kept you a little bit late, but we'll be glad to answer some of your other questions, maybe one-on-one. Thank you very much.